Phone's muted.
Good evening, everybody. Thank you for joining us. This is the first NDX webinar for 2024. We hope you thoroughly enjoyed the end of 2023, the holidays, and are having an amazing kickoff to the new year. And we're grateful you're still here with us on your learning journey. So today we are kicking off with our infamous guest star, Jeff Carlson, CDT. And I'm just going to wait a few more minutes here because I know we've got a few more attendees to come in off of the waiting room. But in case you don't know me, I'm Jessica Respondek. I'm your behind the scenes support. I'm the education manager here at National Dentext. And I'm going to intro the webinar, run through the housekeeping, go through Jeff's amazing bio, and then let him take over the reins for the show today. So the numbers have stopped, and it looks like we are ready to rock and roll. So welcome to the webinar, Restorative Protocol for the Definitive Prosthesis. It is being presented by Jeff Carlson, CDT, and we will begin shortly. General reminder with housekeeping, tonight's content is being recorded for future educational purposes. The question and answers button is located in the middle of the bottom of your screen to the right. Please use the Q&A button for any comments or questions as the presentation moves along, and we'll be more than happy to address all entries as they come along. Please note the Q&A section allows an attendee to ask questions anonymously. Should you not wish to should you not wish to have your name shared with the audience, please be sure to check that option. Chat function, it is located in the middle of the bottom of your screen to the left. Feel free to use the chat box for any technical questions or concerns, or merely to say hello and engage with other participants. Oh, and while I say that, I think I got to open the chat box because it's a newer Zoom feature that I always have to activate as we get in. So now you guys can chat with each other. There we go. Raise your hand. It's located in the middle of the bottom of your screen to the right. Feel free to raise your hand. See me ask your questions live. CE certificates, bear with me because this is a long one. They're going to be used to CE certificates are going to be issued in the next 3 business days to the email address used to register for today's session. Please feel free to email ndxeducation@nationaldentext.com if you don't receive your certificate after 5 business days. And please include your name, course date, and course title to help us search for your record. Please note, to earn a certificate, a participant must be logged in with the email used to register for tonight's session and be engaged in attendance for the length of the course. Failure to meet these guidelines will result in the lack of CE credits. And tonight, if you logged in using somebody else's registration link, we encourage you to log off, register, and log back in with your unique link. Otherwise, we will not know that you attended the event, and the system won't be able to issue you a certificate. Registrations links may be found at nationaldentext.com/education. And if you decided to phone in this evening without logging into your desktop, please email ndxeducation@nationaldentext.com and include your name and phone number, as the system does not recognize phone numbers in the certificate issuance verification process. A post-webinar survey is going to pop up at the close of the webinar in your web browser, and a link will be sent in a follow-up email thanking you for attending. We ask for your completion with valuable feedback and include any suggestions on what you would like to learn about in the future. And one last item before we begin, please know we recognize the abundance of learning options available, and we truly appreciate you for affording NDX Education your time, attention, and participation. And we do have a behind-the-scenes guest today. I'd like to recognize Nicole Smith-Scudder, Senior Manager of Professional Education. Please feel free to chat or reach out with any questions or comments. And she's probably giggling right now because she probably didn't know that I was going to call her out.
In other words, I'm being monitored.
I'm being monitored. So now we go on to our infamous Jeff Carlson, CDT. He is the senior implant specialist. Jeff has extensive experience in both the dental laboratory setting as well as working with dental implant manufacturers in the areas of education and technical and sales support. He has lectured with both nationally and internationally on dental implants. Jeff is the primary author of a 300-page, fully illustrated cookbook for restorative doctors and is a co-author of a corresponding restorative manual for auxiliaries that has been distributed in 8 countries. Jeff has also developed a 2-day training program helping clinicians improve their presentation skills, which has been attended by more than 200 dentists in 16 countries. And with that, it is my pleasure to say, take it away, Jeff.
Why, thank you so much, Jessica. Hello, everyone, and welcome to Restorative Protocol for Definitive Prosthesis. I'm so grateful that you've decided to take some time this evening. For some of you, it's still afternoon. And really hopeful that this will give you some insights and maybe share some tips and pearls. So those of you that may have been some of my actual courses or webinars, I've added some new things here. And so let's get right into it. I do need to do a little disclosure here that I am being compensated as a full-time employee of NDX, and so that's my affiliation here. So when we think about the definitive prosthesis, it's not just a matter of let's start taking impressions, whether we're doing analog scanning. We really need to step back, and this shouldn't be just wait till the day of the patient ready to begin their journey for the final prosthesis. But somewhere through the process, this is some points I wanted to share with you all. So let's talk about some considerations that will help you to make the right decision as far as what type of prosthesis are you going to have fabricated for your patient. So as I thought about this, I looked at some of the real key ones. And then there's some subcategories of each one of these I'll just kind of touch on as well. And one of the things is the opposing dentition, I think many times is overlooked from a standpoint of when you're trying to decide what the prosthesis is going to be. When we get into it toward the end of the presentation, talking about some advantages and disadvantages of some of the different, and key considerations, if you will, for the different final prosthesis. Opposing dentition plays a role because, so let's say the patient has a lot of crown and bridge that they've had done over the years, and there's really, say, nothing wrong with it. And if you go with a zirconia, monolithic zirconia for your final prosthesis, you want to take a look at what is the opposing material. Is it our old-time feldspathic porcelains, which we know that could cause some wear to that? Is it a denture? Is it a partial? Is it natural dentition? Is it broken down dentition? So taking that into consideration, it might help you to decide, well, instead of something as hard as a zirconia, maybe we should go to the hybrid, the titanium bar with acrylic and denture teeth. And we'll go into more detail, but at this stage, we want to be thinking about what is the opposing dentition and how that's going to be affected by our final prosthesis or definitive prosthesis. Then inner arch space or inner occlusal space, as it's referred to, that's really, and we're talking about full arch, that's really measured from the platform of the implant, not the multi-unit abutment, but from not the top of the multi-unit abutment, but from the platform of the implant to the occlusal plane. And when we have cases that at this stage, you've already, patient's been a provisional for several months, probably at least 3 to 4 months. As a restorative clinician, you've seen your patient a couple times, checking their home care, adjusting their occlusion, adjusting their excursive movements, making sure they're comfortable with the occlusal scheme that you're developing prior to getting to this point of the final or definitive prosthesis. So inner arch room was determined early on, and that was also helped to determine how much bone reduction was needed for the case. It also determined about the transition line between the prosthesis and the healed alveolar ridge. So that plays a role too, because some of the restorations require, and we'll talk again about that toward the end, require more room than another. It could be a difference as much as 4 millimeters per arch. So that could be pretty significant. So evaluating that space, measuring it from the prosthesis. If you weren't involved for some reason in the planning, you weren't either there the day of surgery, or you haven't gotten the information, really, maybe you inherited a case. So that's something to evaluate, is how much working space do you have? Keep in mind too, that when you're looking at this, the space, that there's the vertical dimension of occlusion, or what's referred to as the vertical dimension of occlusion. The functional vertical dimension of occlusion is when you're in centric. Then we have our physiological rest position, which is where probably most of you are right now as you're watching this. That means that if your teeth are not touching, when you put your teeth together, that's your freeway space. That's typically around 3 millimeters ideally. So we want to keep in mind too that you need to have freeway space for the patients when we're getting down to the finals. This truly would all be worked out already in the long-term provisional that they've been wearing. So this should not be really a surprise at this point, or too much concern at this point. The other thing is parafunctional habits. We've got these patients, and when I say they're not good dental patients when we started this process, I don't mean that as bad people, of course. I'm talking about their dentition. A lot of them have broken down dentition for different reasons. It could be genetic. It could be just lack of home dental care, poor dentistry, accidents, different things like that can occur. But parafunctional habits, that also is going to play a role into maybe the best choice of the material for the final prosthesis. So evaluate them and see if there's anything that jumps out at you that you want to take into consideration. Then another one that quite often gets overlooked is the hygiene or the home care for a patient. We know that, like, for example, a zirconia prosthesis is much easier for a patient to keep clean and maintain that than, say, the hybrid with denture teeth and acrylic, simply because the materials are not so to attract plaque, and stain is easy. So these patients historically probably have had not the best home hygiene care. So something to take into consideration as well. And then, cost is going to play a role. I think you'll find that, the prosthetics, the final options, between the low end to the high end, you're going to probably have a range of anywhere from $2,500 to $3,000 or more between that. So it's not huge difference, but for some people that are really right at their budget line, that could be significant. So those are some things to kind of consider as you're beginning to really start talking with your laboratory about what are you going to fabricate for the patient. Then I want to talk about some scenarios. So I'm talking to you all as the restorative clinician. I know we've got a few technicians on as well. I think we have maybe some assistants on as well. And hopefully we have some surgeons, implanting surgeons on the call as well. So a patient, when they present to you, maybe they're presenting the day of surgery, they weren't able to load the case. So they decided to bury the implants and deliver an immediate denture. And so the patient presents with a denture. We are not going to cover that option tonight. That pretty much you just be following your conventional all-on-X protocols for the final or definitive prosthesis for that. But what I want to go into detail tonight about is the patient's going to present with a provisional that they've been wearing since the day of surgery, and they would have, with our system at least, and with many systems too, people are picking up 2 prosthetic or provisionals, I should say, at the day of surgery, which really can save a lot on at this point here when we're talking about the definitive prosthesis. So we're going to talk about their existing provisional with a backup or the second provisional that was picked up the day of surgery. What I refer to as picked up, that means that the temporary cylinders or temporary copings were captured into that second provisional, so that if something were to happen during this integration period, if the provisional broke, it's ready you could change out and put this back up in immediately. So the other option that I want to discuss, or the scenario I should say, is that when a patient, they have their provisional been wearing, but for whatever reason at the day of surgery, the second provisional was not picked up. This usually occurs, most often I see it occurring due to some type of a medical necessity, meaning the anesthesiologist, be it that the scenario just says, this has gone on a little bit too long, or the patient's having some issues, blood pressure issues, we need to bring the patient up right away, or the patient is just fatigued to the point where they have backaches, leg aches, their jaw. There's things, for whatever causes us to not take the extra 10 minutes, really is about what it takes, 10 to 12 minutes to pick up that second bridge. So I'm going to cover with you, how do you utilize that backup or that second provisional that was not picked up? So we're going to go into that in detail, and that's going to be new, I think, for a lot of people. So as a reminder, at least with the in-sequence system and with some of the other systems out there, you're going to receive two provisional what we call them a long-term provisional, also referred to, the acronym is LTP, and from the day of surgery, but this is what comes in the kit. And each implant site would have had ordered 2 of the temporary cylinders or temporary copings to allow you to actually pick up the 2 bridges. And then for those of you that may not be familiar with the provisionals that would be coming from this type of a protocol, just to let you know the materials that you're going to be dealing with. The teeth are milled from a PMMA puck, a polymethyl methacrylate puck, and they are monolithic, so they're all 1 unit. And then the actual base is printed from utilizing the Dentistry Lucitone carbon printing material. We're using the Lucitone carbon printers, as you see here. The base is printed, and then we bond using the materials provided by Dentistry, the teeth to this portion of the denture base, or the bridge base. I prefer to call it a bridge versus a denture. So that's the materials. And for some of you that are maybe not familiar with the protocol, so to speak, or how this comes about, I'm going to jump through all the, oops, sorry about that. I'm going to jump through the surgical portion and just say that, okay, here we are, the restoratively, the MUAs, or the multi-unit abutments. If you're using Straumann or some of the other implant systems, Straumann uses the phrase SRA abutments, so screw retained angled. So those have been placed. Now what you see, the temporary cylinders or temporary copings have been seated onto them. This is the bridge as it comes from the laboratory. You saw a tissue gasket that was placed. That's to protect the surgical site so that none of the luting material gets into the surgical site and engages the undercuts, which is no fun when that occurs, from the luting material around the multi-unit abutments. And you're seeing that the bridge then, provisional, is pinned into place utilizing these arms that extend over the metal framework, which we call a bone foundation guide. So now that's ready to lute the bridge to those temporary cylinders. And so then once that is done, then the whether you're using the chairside zest material, or they may have used the Voco Quick Up, they may have used the Stellar material, and the other one is from Stern Gold Easy Pickup, or some of the 4 main materials that we've been told that bond well to these denture-based material. So once the bridge has been luted to the cylinders, then the temporary the small prosthetic screws will be removed. The pins that hold the bridge in place will be removed. And so this typically, picking this up on the day of surgery, is usually around 10 to 15 minutes, just kind of depends. And here you see on the right, this is what the finishing of the provisional now, the conversion, if you will, is very minimal in this protocol. And so then, you know, we know on the day of surgery, unless we had to bury the clinician decided they had to bury the implants or not able to load them at the day of surgery, you're going to have at least one of these long-term provisionals, or the LTP, that would be delivered, you know, finished. By finished, I mean we fill in all the voids. I'm going to show you all that as well, and would be delivered. So at least one, and ideally, ideally, we'd like to see that both of the provisionals were picked up the day of surgery. For you as the restorative clinician, this is a huge benefit, because it's going to really reduce the number of restorative appointments for you and your patient, which does increase the profitability, and it's more convenient for the patient. And it simplifies more so the restorative steps for the definitive prosthesis. You're gonna see how we're able to eliminate utilizing. We don't have to use occlusal rims, open tray impressions, verification jigs, and some of those things. So after that first provisional was picked up, then the clinician, and typically this would be the restorative doctor if they're there at the surgery, or it could be a chairside support person supporting the surgeon. Either way, the second set of temporary copings would be seated, just repeating exactly what was done to pick up the first one. Tissue gasket is placed, and then the second set of copings are alluded to the second provisional, also referred to as the backup provisional. And so then once both bridges have been picked up, then at this stage, the clinician, usually the surgeon's doing this if you're working in a team environment like that, would place these healing caps. By the way, I would really suggest that if you haven't used the contoured, many of the manufacturers now make an oversized or contoured healing caps for these multi-unit abutments, the SRA abutments. That really helps so that at the time of surgery, when the clinician is suturing around these and someone's in the other room finishing up the first provisional for the patient to delivery for the patient to leave with, it really helps to leave they can tighten those sutures really nice around these abutments. And once you remove the healing caps, you still have a kind of an open emergence profile, for a lack of a better term, that it's easier to seat the bridge sometimes with these. So just a thought. And so then at the day of surgery, then they would have placed one of the provisionals and maybe some minor occlusal adjustments, fill in the occlusal screw access holes and dismiss the patient. So that's ideally what would have taken place on the day of surgery. So why is this second bridge very important and beneficial to use a restorative clinician and to your patient? It consolidates multiple appointments. And I think it's important for you all that if you've not worked with in Sequence or other laboratories that are utilizing these type of protocols, that they understand really the value of that extra 10 to 12 minutes to pick up the second bridge, because it really will save everyone a lot of time at the end. So that having this second provisional, as you see here, just as a backup, sitting in a box that waiting for today, the day of the restorative, or for the fabricating the final or definitive prosthesis. So really, it kind of consolidates a lot of these appointments, just this one bridge that was picked up. So it's a huge benefit to have that. So I'm going to share with you now, let's say that they did pick up that second provisional, which was great. It doesn't need to be finished the day of surgery. That can be done anytime after the surgery up to your first restorative appointment, where you want to begin what we're going to also show about taking the final impression, the final bite, etc., for the definitive prosthesis. So let's say that you saw how the one was kind of polished and finished. Let's say that it wasn't done, the second one, and the clinician, the surgeon, just sent it to you, and you need to finish it, or you're going to have your assistant do it, or maybe your technician do it. I want to go through that with you. So what it looks like, this is one that this was at surgery that we've already finished the first one. And so here we need to backfill the little injection holes as need be, which is the buccal portion. We look at the occlusal to backfill the occlusal. All I've done here is wash the blood off of the provisional, dried it, and I reseated the blackout plugs that come with it. And so we're going to need to address these 4 areas. And quite simply, you're going to remove these arms, these extensions, and a disc works fine. You can use a carbide, but this is in real time. I mean, that's very quick to be able to do that, to remove those arms very quickly. Then the remaining portion, you can take a large acrylic burr and just blend and smooth that little nub that's left from when you remove the arms. And then we're looking to backfill the occlusal area. And if you'll notice that the way it's cut out here, you actually have like an occlusal matrix, so to speak, where I like to take some flowable composite. You don't have to do this. I think it's nice for the patient to have white occlusals, especially on a lower. They're paying good money for this. And so I like to come in with a little bit of flowable, and I'm using the edges of that occlusal as my reference point for reshaping and recontouring a lingual cusp, that you see here now on the bicuspid. It's a little more freehanding that. Hit that with a light cure before it slumps. Otherwise, you can come in. This is a Voco light cure material being utilized and just flowing around that, blending that. And then you need to, once you do from the occlusal perspective, on the integral side, you want to fill in any little voids here. You want to have a nice transition from the base, the integral surface, up to the collar of the temporary coping. Think hygiene here, which is very important. We don't want to have any food traps here. So we want things to be polished, smooth, and no voids. Then you want to come back in and, just blend everything again. This is just a lot of quick, blending. If you don't add too much material, get carried away adding material, you really should be able to finish one of these bridges in 15 to 20 minutes. But again, this isn't with the patient in the chair. This is any time after the day of surgery. So this could be maybe sitting there for 3 months or so, and you're just have your patient coming in next week. You're getting the backup ready for the day to taking the final impression. So that's what you're going to be doing. And again, just a little bit of rubber wheeling. I like to use a stiff bristle brush and do some nice blending and smoothing here. So we're just getting this prepared. Now, quite frankly, you're going to see that this might be a little bit of an oxymoron as I think about this, to spend too much time on the integral side here, because literally based on how you're going to, you've got some options when you do your final impression. Are you going to utilize the bridge that the temporary bridge they've been wearing for several months, or are you going to use this backup provisional to do the final impression? So we're going to talk about both those options as well. And so it's just going to basically, polish and, have everything, have everything nice and polished for the patient. But if we're going to do another option where you're going to utilize that, you don't need to go into that much time and polishing it. I'll explain that coming up. Okay, so now we're ready again to go ahead and begin the impressioning protocol for our definitive prosthesis. Again, using this technique and technology, we don't have to follow the conventional all-on-X protocols, which condenses or consolidates a lot of these appointments. So it depends on what you're looking at, trying to, what's needed to be achieved here. You could be 2 restorative appointments to deliver a final prosthesis. First appointment would be the impression and a final bite, and then deliver that backup duplicate for them to wear. Or you may decide that the second appointment could be the final, or you may decide that you want to have a wax try-in before you go to the final, which there's nothing wrong with that at all, especially if you have a patient that is very demanding aesthetically. Let's get it right instead of waiting to get to the final and have them go, well, you know what about, and they start pointing at things and you're looking at zirconia restoration and it's a do-over. So something to think about. So usually it's 3 appointments, and each appointment really shouldn't be more than about an hour long for you. Again, it's not a race, but that's not uncommon for each appointment to be about 1 hour appointment. So let's talk about some of our options here. So one option is going to be, if we're going to utilize the patient's existing provisional that they've been wearing for the final impression. This is probably the recommended way to do it for several reasons. One is that this provisional they've been wearing for 4, 5, 6 months, you fine-tune the occlusion quite well with it. The occlusal scheme, maybe the lab just needs to redefine some of the anatomy to make it a little more better, cusp-phos relationship, better for mastication for the patient. So using the existing long-term provisional is really I think is preferred way of doing it. So what you would do, patient arrives, you discuss with the patient how they like and everything that they've been wearing. Is there any changes that they would like to make those notes, those documentations. Then what you're going to want to do is remove the provisional that they've been wearing. And then you're going to take a large acrylic burr and then just grind, make sure you have at least 1 to 2 millimeters of space here. As you see in this image, there's a pretty good space right here, but you don't always have that space throughout the integular surface between the healed alveolar ridge and the integular side of your provisional. So we want to get a really nice final impression. That's really going to be important. So this is an important step to do, is to create that space there. And then, since we're going to be taking an impression with this, we want to put some tray adhesive all on that integular surface, and even bring some of that tray adhesive out onto the peripheral borders here of the provisional. So now we've done that. The other alternative is you could go ahead and you can take and use the backup bridge to do the final impression with. Now, this would be another option. And so ahead of time, you would have gone ahead and relieved that by about 1 to 2 millimeters here, which this is what I was referring to when I was showing you polishing that bridge. If you're going to use the backup that's been sitting there for several months to do the final impression, don't polish the integular side. It's actually probably a little bit better if it's a little rough. So you need to just make that call on whether you need to, do this, create the space or not. But once again, if we're using this backup, you're going to want to put tray adhesive on it. Then you would remove the bridge that they've been wearing, and then you're going to seat this backup bridge, and we're going to go take the final impression. So whether we're taking an impression with the backup in place or the bridge that they've been wearing for the last 4, 5, 6 months, whatever it's been, we're going to do the same thing here. So this could be either the backup bridge in place with the tray adhesive applied, or it could be the existing bridge creating the gap under either scenario with tray adhesive. And so what you're going to want to do is utilizing the small syringe tip and using a medium, I think a medium PVS material seems to really probably work about the best. What you want to do is insert the tip of the impression syringe posteriorly as far back as you can, and push it under the bridge and inject until you see it come out the palate or the lingual, if you're doing the lower. And then do like a sewing machine, you kind of come in and out, and work your way toward the midline. And then once you get to the midline, go to the other side, again, posteriorly inject it, same area, and then in and out, working forward to the midline. You'll find it's easier to start posteriorly working toward the midline. You can see what you're doing, and it gives you more control of the impression material than trying to just go all the way around and running the bead. Again, getting a good impression here is really critical. And if you feel like you didn't get a good impression, once you take it out and look at it, you can always ask for a wax try-in, and then on the wax try-in appointment, pick up those voids, or redo the impression under your try-in. So once you've done from one posterior to the midline, the other side posterior to the midline, then what's very important to do before it's set, so you got to move pretty quickly here, is run a nice large bead across the entire transition line on the buccal and palatal or lingual area, over the retromolar pads, over the hamular notch, just capturing 360 around the bridge of the anatomy. That's going to allow the laboratory to really give you a nice adaptation of the final prosthesis to the healed alveolar ridge. So then we're always going to want to take a new bite registration. This is going to be mandatory. This is important because things could have changed over time. And so especially if you're using that backup, which you've not done the occlusal adjustments to that backup bridge. So if you're using the backup bridge to take the final impression to send to the laboratory, you would need to do a full occlusal adjustment on that, make sure you get all your excursive movements. So I think people that elect to use that backup that's been sitting there for so long, it's utilized usually when they didn't do a lot of occlusal adjustments during the integration period. And maybe at this stage, maybe it takes 5-10 minutes to fine tune the occlusion, but it's entirely up to you. You have that option of doing that, using the backup provisional, or using the one they've been wearing. So you want to take a bite registration. It could be a digital or an analog. But again, regardless, you want to take a new bite registration and then a new opposing. And once again, that can be digital or an analog. Always take a new opposing. Over the period of those months of integration, something could have changed. And especially if you're wanting to go to a final prosthesis, the records that the laboratory would have, whether it's a model that you sent in, or from a scan that you sent in, an iOS scan that you sent in for the fabrication, for the day of surgery, for the fabrication, those provisionals way back then, things could definitely have changed. So just know you want to take opposing new impression. And then if there's changes to it, take some photos as well. Make any marks on it. Give the lab as much information as possible of what you and your patient are looking for. If the modifications are significant, then it would probably be a good idea for you to go ahead and have a wax try-in. Wax try-ins can be very beneficial. It's that one last time to make sure that they're okay with their final what their final prosthesis is going to look like. Then you would send all that information to your laboratory. Your second appointment could literally be deliver the final definitive prosthesis. Or again, if you wanted, you could go to a try-in for the second appointment. The thing I would say about delivering the final is always allow, another 15 or 20 minutes after what you've scheduled for yourself, restorative doctor, of delivering the prosthesis to the patient, to meet with the hygienist. And here's why. You're going to see that their provisional was much easier from a hygienic perspective for the patient to maintain. There were probably some little spaces there, and it was easier for them to get a water pick in there, floss threaders, etc. So your hygienist is likely going to have to retrain them or train them of how to do their home care on their new final, because it's going to be pretty snug here. And there might need to be some different types of tricks or utilization of instruments. When I say instruments, not necessarily hard instruments, but floss threaders, super floss, things like that for the patient. So make sure that your hygienist has time after your appointment for them, or schedule them shortly thereafter for it. Either way, don't let them go a prolonged period of time before they get retrained or trained on how to manage their home care on their final prosthesis. So again, you could do the final, or that second appointment could be the try-in appointment. So if you're doing the try-in, you'd remove, obviously, the bridge they've been wearing. And it's always a good idea to show the patient how, if they're doing good with their home care, show them how good it looks. If they're not doing good, be sure and show them that. Show them what it looks like here. Most of you have intraoral cameras. You know how it is. You show it on a big screen at 34, that 40-inch screen or whatever you have in the operatory. When they see that, it's kind of like, wow, you might have to give them a little bit a talking to make sure they're doing a good job, because the last thing you want is this patient due to poor home care, get some periimplantitis and cause some issues that are not necessary. So then again, if you didn't get a good impression, or let's say you didn't even take a final impression at that other appointment, you could do that now. Again, tray adhesive, pretty much the same thing we talked about before, and do a wash impression in this wax try-in. And then if you haven't taken the new opposing, do that, new opposing impression and a bite with this wax try-in. So hopefully you've kind of got a feel for that. So I shared the scenario. What's the way when everything's been picked up, and then if one picked up and finished, and then if one wasn't picked up and finished, how to finish that second long-term provisional. I'm going to share with you now something that, let's say that they literally did not pick up the second bridge, the second long-term provisional for whatever reason on the day of surgery. So basically what you have is the bridge, as you saw, with, basically just this. It may even still have the arms on it. But just to be clear, what I'm sharing with you now is only if the second provisional was not picked up utilizing the second set of temporary copings on the day of surgery. So you don't have to, you still can utilize this. You don't have to do open tray impressions and, custom impression trays and do the conventional all-on-X protocol to do the final or definitive prosthesis. So that's what I want to share with you now. Okay, so let's think about this. Here's the patient, how they present after 4 or 5 months. Again, this is our first appointment. We're going to do our final impression. We want to get started on that definitive prosthesis. So the patient presents like this. What you want to do is do not apply any tray adhesive, utilizing that small syringe tip and the little technique I mentioned before, just kind of going in and out. Inject medium body, again, is going to work the best for you. PVS all the way around, just like I showed you before for the final impression. The only thing different here is that you do not have tray adhesive on the provisional bridge here. Pardon me. So once that sets up and you remove the temporary bridge, I'm terribly sorry, dry throat. This is what I refer to as like a seating jig or a seating gasket. It doesn't look like much here, but I tell you, long as you get some that when you did that bead, you got over the buccal or palatal or lingual alveolar ridge to kind of give a seating position. If you could imagine taking this now and going back to the mouth, where here we have, those temporary copings should be in a crown box, utilizing our system either way. If you're utilizing our system, you would have that second set of copings in the crown box for each implant site that was dedicated, pre-cut for each implant site. So you would seat the cylinders onto the multi-unit abutments. And then what you would do is seat the seating jig over those abutments. And again, that will find its little resting spot, if you will, on the alveolar ridge. If you got it, did a decent job. This works quite well. I've done it quite a few times. The one thing I put here in this little note box that you want to watch out for is that now this has, as you see here, this tissue is pretty tight on this particular patient. There's really not much of an opportunity at all from this view anyways. And if I recall the case, it was you're not going to worry about luting material getting up underneath this coping, and especially getting to the SRA abutment or the multi-unit abutment and locking that provisional in, which is not a good day. So keep in mind, if you see, maybe the sulcus around these implant sites, there may be a little more of a gap, if you will, that it's a really good idea. Just take a quick rubber dam and drop a rubber dam over that and seat this gasket over it. The rubber dam, and I find what works really better than the conventional rubber dams, is actually just a glove. It's thinner than those rubber dams, and it really doesn't have a lot of effect on the fit of this jig fitting over the alveolar ridge. So we got our second set of copings in place. We've got our positioning jig seated over that. And now what we're going to do is we're going to take that provisional that has the holes in it, that's unfinished, of course, because we never did pick up the cylinders the day of surgery. And you're going to seat the bridge into that gasket. Then what I like to do is have the patient closed down. So nothing's fixated. The bridge, I should say, is not fixated, and even the gasket isn't. So you're going to have to keep your fingers here and hold that in position. Have the patient close in. What we're checking at this stage here is, to make sure that they can go into center of occlusion, that these copings were not too tall. Maybe it might be a good idea if the copings are hitting to adjust that coping. If you use copious amounts of water, you can do it right in the mouth with a high speed. Those temporary cylinders reduce fairly easy, but just use lots of water. If you're worried about it, just unscrew it. Just takes a few seconds to do that, and then outside the mouth, shorten up that coping. But so I like to just see that one can make it into the centric. And what you're doing here literally is we're utilizing the positioning jig, or the positioning jig and the occlusion to get that bridge into the right position. So all I'm doing right now is I'm just kind of verifying, how does that look? Okay, so I've verified it. So now I'm getting ready to lute only 2 cylinders first off. Now, my little note box is going to pop up here. I have to apologize. You're going to see some images here. And it's with what we used to use, we called it a clear bridge or a clear duplicate. We've quit using that for a few years now, a couple of years, and I have lost the slides that are of the current protocol. But please note, it's exactly the same. It's just that you're looking at a clear second provisional. We refer to it as a duplicate instead of the pink with the denture teeth, not with the denture teeth, but with the teeth on it. So it would be an exact replica of your backup that I've been showing you. So we've tried it in place. We verified that everything's fitting good. So I like to, there'll be holes. These injection holes are, buccal injection holes are already there. And to inject some material, don't get carried away, just get some material injected so you're getting material, the luting material, around that gingival area of the coping to the bridge. We want to get a good, a good adaptation and flow of that material completely around the cylinder. And I like to do just 2 of them. Maybe you do, canine area-ish. It just kind of depends on where the implants are, of course. But, you don't want to do one in the posterior here and one in the, molar to molar here. Try to get something on each quadrant, basically what we're shooting for. And then the other thing, what I like to do is before you either light cure the material or before it sets up, if you're using a self-cure material, is to have the patient open. Again, you're holding it in place, and then just, add a little bit more material. You want to make sure, of course, that you don't get anything into the screw access hole. Next slide, I'm going to talk a little bit about blocking out. I just didn't have it here. But now we've got material that we know we're good here from the gingival area. We came in from the occlusal and kind of filled in little voids. Our goal is just to have enough material that locks that temporary coping to the bridge. So we still haven't set up yet. We haven't light cured it. Now we're going to close the patient down again. And then if you are using light cure material, light cure those 2 areas, or, wait till it sets up. And then you can open up and then go ahead and add the other blockout plugs with the patient open, and makes it real easy to backfill here. So here's a point. If you're concerned about getting material up over those cylinders on the first 2 that you're going to lute in a closed, or in a, patient closed into occlusion, these blockout plugs, they should still be in that little crown box as well. Just cut them just to the top or a little taller. You just want to make sure that these plugs are not preventing you from the patient getting into occlusion, which could malposition your bridge. Hopefully that makes sense to you all. But I just found if you're not too aggressive, again, we're not trying to completely fill this whole void. We're wanting to make sure that we have enough material, 50%, 75%, so that that cylinder is bonded to the bridge. So now that those 2 were bonded, we open up the patient can open the bridge. We can just check down. Yep, it looks good. With the patient open, then just go ahead and insert the blockout plugs. You don't have to trim them or cut them, because then you're just going to go ahead and then backfill or inject those through those buccal holes, inject your luting material, come in from the occlusal, easy to see everything, take a perio probe, go around it, pop it in the air bubbles, etc. And again, we're just really looking to make sure we got enough material around the cylinders to bond to the provisional. Once that sets up, or you light cure it, then you pull out your plugs, remove the and you're going to have to, the arms will have to have been removed from the bridge, of course, because those are going to get in your way. I don't recall if I mentioned that in a couple of slides previously. So if you do have the arms there, you need to remove those arms, those extensions off of it, because we're not utilizing that metal bone foundation guide as a reference point to pin this bridge into place. So now everything is set up. Then it's a matter of you remove it, and it's back to what I showed you before. You want to backfill this little area here, fill in the occlusals. And again, as far as the integulo side, how much smoothing you're going to do, it's based upon what are you doing with this bridge. Is this the one that you're going to take the impression with and send that to the laboratory? Or is this the one that you're just going to deliver, let the patient leave with? If you're going to deliver this, adjust the occlusion, and let the patient leave with it, which could be a nice motivation, especially if the first one was a little bit stained. Maybe there's even a little fracture on it or something like that, but they get a brand new bridge. And then that one that they've been wearing goes back to the laboratory to scan and to begin either for a wax try-in for the second appointment or to the definitive prosthesis. So how far you take to finish in this bridge is going to be based upon what are you going to utilize this bridge for. I hope that makes sense to you all. So then we're going to have the seat this bridge. And again, you're either going to use this backup bridge as the impression, or you can use the backup bridge for the patient to leave with. As we just discussed, it's either way, it's your call on how you want to do that. So I'm going to wrap up now, just talking about, I've taken a couple of minutes talking about the options for the definitive prosthesis, and then we're going to have our Q&A. So let's take a look. There are a couple other ways. These are the 4 most common ways or prosthetic options for your definitive prosthesis. The one we've been doing for many years is referred to as a hybrid denture teeth and acrylic with a titanium bar, which of course you can't see the titanium bar in here. The other is zirconia, which we're seeing, this is probably the most popular one that's utilized, monolithic zirconia, nanoceramic, and we're going to talk about each one of these, but a little bit about, kind of the considerations and contraindications, if you will, for these. And then the last one, which is the high-end one, is a titanium understructure with what we refer to as a thimble bar. These are 12 individual crowns. We only go to first molar occlusion, typically, and then that's just something like a Garadia type of material that is hand done. So let's go into each one of these a little bit more in depth. So let's take a look at the hybrid. I also included here about inner arch space that I referred to early on in the presentation. So reason that this restoration needs the most inner arch space is because when you get less than about that 14 millimeters of material, denture teeth and acrylic, there's a higher propensity for teeth to pop off, especially when I've done some that were like 9 millimeters, and we're popping teeth off all the time, putting patient in a night guard. But we need more room here for the strength of the prosthesis. So considerations, mentioned a little bit earlier about the opposing. This is going to be the kindest to the opposing dentition. So, and if this wears, well, you know what? The good news is these teeth can be replaced. You can do, as you think about doing a denture, a jump. Those my removable friends out there understand what that is, but you can replace the denture teeth if they got worn. You can replace the acrylic. The framework, nothing's going to happen to that framework. It shouldn't happen to that framework the lifetime of the patient, quite honestly. So there's some benefits for this. If a patient has parafunction, that you got to really think about this could be advantageous to have, again, because of wear, or it could be a problem because it could be breaking teeth off consistently. Drawbacks, I already mentioned that it's basically a denture, so you're still going to have potential staining that could occur. And let's jump to our zirconia. So zirconia, we're at what are we, about our 7th or 8th generation now of our zirconia materials. It's fantastic. I really like what's now out there is a multi-layered zirconia. So it's just a significant amount of money. I'm talking about maybe, you know, $100 or more dollars, if even that, for a multi-layered, and it kind of just depends. But it gives a little more translucency, a more natural look, even though the zirconia, just a standard monolithic zirconia, looks really nice. So zirconia, what we're comfortable is saying that the inner arch space here up to about 12 millimeters. So that's where you can see almost 4 millimeters of difference potentially between this type of a prosthesis than the hybrid. You know, parafunctional habits, again, we just talked about that. Posing, if you're going to posing double arch, zirconia against zirconia, people talk about, you know, a lot of noise that it can possibly make. It's a drawback down here, the clacking. Quite honestly, the hygiene is much better. Probably the best of all of them is with this type of a restoration for a patient, much easier for them to keep it clean. And, you know, a little bit more expensive than the hybrid, usually not too much difference than the next option we're going to talk about, which is the nanoceramic. And the nanoceramic, for those of you not familiar with it, instead of a titanium understructure, the material is called Trilor, and it's milled also from a puck. And it is a like a PMMA material that's impregnated with nanoceramic particles. And the material is very strong and actually has a slight modulolasticity. You can't feel when you can't move it in your hands, but it is a little kinder to the system. When a patient goes into function, it doesn't have that same shock effect as, say, the zirconia does. So we're going to fabricate the understructure, scan that, and then we're going to mill from another puck of the Crystal Ultra the actual teeth and the shell, if you will, the buccal and palatal or buccal lingual portions of it, with already the cutback configured into it. Then that at the laboratory gets bonded. This gets bonded to the framework understructure. Then the laboratory is going to polish and high shine the teeth. They'll then hand apply like a Gradia, a lab light cured pink material. Inkst is another a German product that's utilized a lot here for that. And then they would do a light cure glaze, like an optoglaze over that. This has, you know, this is about a 13 millimeter inner arch room. Can you go to 12? You know, those things can be done, but we just want to, there's got to be a target, and we have to some reference point, a go, no go, but some type of a reference points to work from. This, again, a little bit kinder to the system. If a patient does fracture or chip off a cusp, it's repairable. You can use your flowable composites and do a nice job repairing it. I've actually relined a few of them if need be. The glaze does need to be replied, probably depends on the patient's habits, home care, etc. Maybe, you know, once a year, once every couple of years. But it's doable. So then the last one I wanted to cover, and then we'll take questions, is what we refer to as a thimble bar. And with 12 zirconia crowns, there's an option for Emax crowns. There's an upcharge for doing that. For this, we're looking at also about 13 millimeters. This is going to be your most aesthetic situation for a patient. They're individual crowns. We bond everything. The crowns are all bonded to the framework. You just have the 4 screws or 5 screws or 6 screws. Depends on how many implants you have to screw this prosthesis into place. And you know, it is the higher cost of the options. So having covered that, I just want to say that we do have additional information. There's more coming. I'm working on updating a lot of our presentations on our website in the coming months. But if you go to our homepage at insequence.com under education, there'll be a drop down virtual learning academy. There's things, other topics there. Multiple of them are for CE credits as well. You just register. And to let you know, you get a chance to hear our Kelly Bevington, Brittany, and Brenda really go into some great detail on the complications for iTero scanning. That's coming up January 30th. It's a Tuesday. Don't miss that one. And I want to say thank you so much for your time this evening. And I'm ready to take some questions. That's my LinkedIn profile if you want to catch me on LinkedIn or anything. So Jessica, if you want to open up and let's see what we got going out there.
Great presentation, Jeff. Always thorough and tons of info. And we do have a question.
Yeah.
What's important to capture and how best to capture it when impressing for the final prosthesis?
So really the entire alveolar ridge is important. Even the crest of the ridge, because it allows for better adaptation. If the laboratory sees what that tissue is like, when they finish off the actual integular surface of the final, they want to keep that as smooth as possible. And it's a great question too. Thank you for asking that, because if you have a case that, say, the surgeon left the tissue where it was less than desirable as far as the contour, maybe they had they tightened the tissue up and there was a lot of excess tissue and you've got all these high points in the alveolar ridge, you may really want to consider, if you're not comfortable doing it yourself, refer it back to the surgeon, whether it's the oral surgeon or periodontist or a colleague that did the surgery for you. And, whether you use a laser or maybe you use, a diamond burr and try to, recontour or smooth some of that tissue up. We really want to have, don't want to have a lot of voids, or concavities are the worst thing, because concavities, you can't clean that. Your best chance with that is going to be with a water pick. So we want to capture the entire surface contacting the alveolar ridge with a focus on, well, I'll focus on all of it, but wherever the bridge is going to end, the transition line as well, because sometimes you need to create a little bit of room for a patient to get a floss threader in there as well. So it's really the anatomy underneath the bridge that you want to make sure you capture that very accurately. Thanks for the question.
Great, thank you. And that is all the question. Oh, wait. I was able to immediately load the posterior 4 of 6 implants, letting the anterior 2 implants cook for a few months. I picked up both LTPs on those 4 implants during surgery.
Perfect.
What is the most efficient route to add the anterior 2 implants to the provisional / definitive prosthetic, assuming they're solid on the torque test?
Yeah. Oh, awesome. And I hope all you'll hear this. That is what you want to do, is to pick up, even if you're, and let's say if you're not, if you've got some implants like that, and you're going to cut off a cantilever, let's say you weren't comfortable with the terminal implants. So doctor, if we turn that around and say that you had maybe everything but a terminal implant or a terminal 2 implants, and you had to cut the bridge, still, if you weren't ready to load them, but go ahead and pick those up in that other provisional, because or not necessarily pick them up in that provisional. Don't cut the cantilever off that second provisional. Leave that there. So to your specific case, doctor, with the 2 anteriors, it's very similar to what we just showed you. It's actually going to be easier because you're going to be able to utilize those other 4 implants to position it. So I would say what you would do is put the 2 temporary copings on and seat the bridge, make sure you got a path of insertion that you don't have to relieve inside that provisional at all. Then very importantly, I think it's a good idea here, take a rubber dam, probably, just the size of a dime around those copings, and drop a rubber dam around them. Maybe they're close enough, you just do 1-piece rubber dam. Again, you don't want to get any material locking underneath those multi-unit abutments. And with the patient open, you can, I still like to, if you have the buccal injection holes available, always inject there first, because it's better to inject from the gingival up, if you will, then from the occlusal down, you cannot see if you're getting an air bubble trap there or not. So it's better to go from the buccal injection hole, watch it fill up, then you can jump around back to the occlusal, maybe throw some blockout plugs in there just to help prevent anything from accidentally flowing into that screw access hole. And, and just pick those up and remove it, and then just finish off the integular area like we showed you and the occlusal area, and you're good to go.
Great, thank you. I am not seeing any other questions. Thank you again, Jeff, for being here, sharing your wealth of information. And what would you like to share?
I just wanted to say too, for you all, thank you. Hi to everyone as well. Thank you for the hands coming all up. There's my email address. If something comes up, we appreciate you guys logging in and spend your time with us. We're really here to help provide solutions for you and help you have success with your cases. So please feel free to reach out to me if you have other questions. I'm more than happy to get back to you. So thank you all again for your time.
Thank you all. Take care of those patients, and don't forget to tell us how we can take care of you by completing that survey at the end.
All right.
Good night, and we'll see you on the next webinar.